So first of all, they all found this to be a very useful way to talk to patients. So we created a behaviorally tailored method of patient interviewing that elicited from patients what their barriers were and then intervened upon them, which is very different than what clinicians, myself as a physician included, typically do. We listen to patients often for a few seconds and then quickly say, okay, here's what we're gonna do. We're very transactional. But the literature and behavior change more generally tells us that we should actually spend some time to figure out what patients' individual barriers are. And so what we did with them was develop a way to do that on the phone and briefly. It's called brief negotiated interviewing. And on average, these calls were 20 to 25 minutes by phone, as opposed to hours in person, which limits scalability. And so they found this method of interacting with patients to be ultimately quite natural and helpful. The second thing that we found out that was quite interesting is that there was about a third of patients who the claims data said patients were non-adherent, who the pharmacist thought were actually adherent, which in and of itself was surprising. And that there were in some cases, very legitimate reasons for this. The patient had been told to stop a medication during the period of time we were trying to assess adherence in the before randomization. And it looked like they were not adherent, but they were appropriately adherent. That was about 10% of patients. Their clinicians were changing their medications around. In another proportion of patients, they were actually filling from other health insurance providers. So they may have had two insurers, for example, or they may be paying cash as opposed to using their insurance for reasons that are peculiar to themselves. And so the claims data might have actually been inaccurate. They weren't capturing the totality of the experience. And so while we use claims, myself included, all the time to evaluate outcomes, we use them for payment methods, for paper performance, for Medicare STARS measures. It was surprising that we found that the pharmacists during these interviews thought that the claims were somehow not representative in this many patients. Now, of course, it's important to remember that during a conversation, patients will often report things that may not be reality. There's a social desirability bias to please the interviewer. And so when you ask patients whether they're adherent, patients will usually report that they are, even in cases when we know that they're not. And so this estimate of how inaccurate the claims are may be a bit of an overestimate, but nevertheless, in a real world system with real clinical pharmacists working in a real delivery network, finding this through interviews, which we did with more than 1,000 patients, was quite surprising.